Next, I am going to talk about why nutrition is so important in pediatrics and define and discuss the etiology of undernutrition. I will define what undernutrition is and then discuss different etiologies, and then I'm going to talk about the classification of protein energy malnutrition, the previous classifications, as well as some sort of new paradigm shift on protein energy malnutrition definition and classification, and then the assessment of children with undernutrition, the management of different levels of undernutrition, and at the end I will discuss a little bit about nutritional rehabilitation and prevention of undernutrition. Why nutrition is so important in pediatrics? I'm sure that everybody is aware the children are growing. So for the growth, micronutrients as well as macronutrients are very important. During the first 100 days of life, as you know, is very critical about the physical growth as well as brain development. For the physical growth, macronutrients, at the same time there's some micronutrients like zinc, selenium, and all these micronutrients are very important. For the brain development, again, would start with the development of neural tube, which in turn again needs a lot of micronutrients like folic acid, then iron and copper are important, and a lot of free fatty acids as well as unsaturated and polyunsaturated fatty acids are important factors which would help in the development of the brain. The deprivation of this nutrition during this period can lead to growth failure as well as the reduction of order, can lead to low IQ and low psychomotor development. Then what about infections? For immunity, for both innate immunity as well as cell-mediated immunity, one of the micronutrients, mainly the proteins and lipids, as well as some micronutrients like vitamin zinc, vitamin A are important. So those children who are deprived of nutrition again will not have the full growth potential. When we talk about linear growth, as you know, just after birth, during the first year of life, sometimes we call it first 2 years of life, the main determinant of the linear growth, the main factor which will determine whether you are getting a good growth is the nutrition. Later only the other hormones and all other factors come into the picture. So during the infancy, the linear growth is also affected if the child is deprived of nutrition. Right. So what are the common nutritional problems in Sri Lanka? When compared to 2 decades, we are little better, but still the stunting, that is chronic malnutrition, the wasting, the acute malnutrition are common. We don't see much kwashiorkor and marans, because those are the clinical extremes of protein energy malnutrition, and it's very rare, I should say, in the areas that in southern part of this country, and still I think it's common among the children in some estate population. Then the micronutrient deficiencies, the vitamin E deficiency, though we live in a temperate country, it's more than 12 hours of sunlight, but still we see rickets and nutritional rickets, vitamin D deficiency. Then iron deficiency is still a problem in Sri Lanka. The zinc deficiency is also common. As you know, still 1/3 of our pediatric population are underweight, and 1/4 of them are having low height for age, that means having chronic malnutrition. So this figure shows that in 2016, we are better with chronic malnutrition, but still we see a lot of children. Every area is affected by the acute malnutrition. So what is the definition of undernutrition? So WHO defines the undernutrition is a cellular imbalance between supply of nutrients and energy and the body's demand for them to ensure growth, maintenance, and specific function. So, American Society of Enteral and Parental Nutrition defines and there's an imbalance between nutritional requirement and intake, resulting in cumulative deficit of energy, protein, and micronutrients that may negatively affect growth, development, and other relevant outcomes. So, I think that American Society of Enteral and Parental Nutrition covers more, and I think that not only it affects the growth, it affects the development, psychomotor development, as well as other relevant outcomes, especially the IQ and all. So this is the definition of undernutrition. When you're talking about the common causes of undernutrition, when you take all over the world, the commonest cause is still is the unavailability of food. Is the commonest factor, but in Sri Lanka, of course, my personal belief is that rather than the unavailability, the malpractices and food habits and taboos and feeding behaviors are the main cause for malnutrition in Sri Lanka. But I agree in some population where the socioeconomic condition is poor, the unavailability of food is also play a big role. But in Sri Lanka, in most of the literature says in developing countries, the commonest cause is unavailability. I think they are referring to most of the African countries. But in Sri Lanka, naturally, we have a lot of food which can be sort of low-cost food available, but it is not, those are underutilized, I should say. So rather than the unavailability, the food habits, taboos, and the feeding behavior is the common causes of malnutrition, cause for malnutrition in Sri Lanka among children. The other reason is the chronic illnesses. Chronic illnesses can lead to nutritional problems. This chronic illness would attribute to a nutrient loss, for example, protein losing enteropathy or chronic diarrhea, chronic infections can lead to nutritional loss. Sometimes, in some conditions, the chronic illnesses, the energy expenditure is high. So energy requirement is high when compared to the normal peers of these children. So, for example, the congenital heart disease or asthma, those children, the work of breathing is high. So they need usually 30% more energy in order to maintain that increased demand. As we all know, when you are ill, your appetite is very poor. So on top of that, the chronic illnesses with the increased demand and the loss, the appetite is also lost during illnesses. Therefore, the chronic illness is one of the major causes of undernutrition in children. So the low immunity causes infection. Infection again causes poor nutrition. So it's a two-way thing. Then the children, some children who are at risk of development of nutritional deficiencies, babies who are premature, who are having developmental delay, for patients with cerebral palsy or feeding difficulties, and children with asymmetrical IUGR. Their enemy is small to start with, so they need to catch up, especially the premature babies and IUGR babies need to catch up their weight. Some babies fail to do so. So what they say is about 30% of babies who born IUGR will not catch up their weight. So they would remain small throughout their life. Though it is not common, food allergies, again, multiple food allergies, would again, a child would face the nutritional challenge because there are a lot of dietary restrictions should be done in food allergies. So these are the common causes of undernutrition. And these are the two pictures. I think it's very much familiar with you. If you go through this chart, right? So this diagram, most of the things which we will not be able to control, like the basic causes, are beyond our control. And then the underlying causes also, again, that depends on the policymakers. But immediate causes, of course, from that point and onwards, we have some control. So the disease-caused malnutrition leads to, again, inadequate dietary intake. So what are the consequences of malnutrition? The short-term consequences, as you know, morbidity and mortality, and the long-term consequences are actually which would affect the future generation, the size of the stature, and then the intellectual capacity, the reproductive performance, and in turn, the economic production of the country will be affected. So therefore, this is malnutrition. This chart, when you go through, most of the things are not under our control, but some of these are under our control. Then you see the next chart, the small one, which again, the vicious cycle of illness and malnutrition. That's this vicious cycle goes on. The child would remain undernourished most of the time, then it can lead to the poor nutrition. So, therefore, we have to break this vicious cycle at some stage. Otherwise, child would end up with the long-term consequences of malnutrition. Right. From here onwards, I'm going to talk about protein energy malnutrition first. So these are the two pictures of the extremes of protein energy malnutrition. So the child who is seated is having marasmus, and you can see the big tummy as well. So I would say it's a marasmic kwashiorkor. And there's an edema of the leg, and so fortunately in our country we don't see this kind of children. The other picture is the full-blown kwashiorkor with edema and sparse hair and apathetic look and all, and the same child after the treatment. So you can see the difference of the faces of this child. The child, once the child is treated, the child is very active and very pleasant. So protein energy malnutrition, there are different classifications of protein energy malnutrition. Why do we need to have classification of protein energy malnutrition? Actually, to define the type and severity of the malnutrition and the duration. So we need to classify it. So there are different types of protein malnutrition. So acute protein malnutrition or a chronic protein malnutrition is stunting, and then with classification we know whether it is an acute thing or a chronic thing. The other reasons why we need this classification is for the epidemiological purposes and the research purposes. At the same time, when you categorize it, it's easy for the communication with your staff as well as the supportive staff in order to plan your management. So we'll see how this protein energy malnutrition is classified. So what are the parameters that you use in the classification? So anthropometric measurements are the baseline of the basic measurement that we use to classify protein energy malnutrition. In some classifications, we take clinical features, but for biochemical indices are not used in the clinical classification, but definitely the biochemical indices are different in different kind of malnutrition. For example, in marasmus versus kwashiorkor, their biochemical indices are different. So here is the summary of different classification of protein energy malnutrition. First of all, I will talk about Gomez's classification. In your medical students days, you learned that. And actually it was introduced in 1956, long ago. There is malnutrition is classified the weight for age, and the parameters, anthropometric measures that we have taken is only the weight. So weight more than weight loss, the percentage loss for more than 40% we call severe malnutrition, 25 to 40 we say moderate malnutrition, and 10 to 50 we call mild protein energy malnutrition. Here there are some problems with Gomez's classification. It's a very primitive classification, and though it is easy to use, and only the weight is taken sometimes. In our country, of course, the age we know, but countries where sometimes illiterate mothers will not know the age of the children, then so we will not be able to use this chart. So at the same time, about 10% of the normal population also is categorized as having malnutrition in Gomez's classification. So then we take about the Wellcome classification. We take not only the weight for age, but also weight deficit, but we take the clinical features as well, whether the edema plus or negative. So there, this is better than the Gomez's classification, but still we take only the weight for age, especially when the edema present. The weight is not a good indicator to use, because edema also leads to increased weight. So here the duration is not expressed. We don't know if it's acute malnutrition or a chronic malnutrition. But the good thing of this classification is they look for presence of edema or absence of edema. Then for a long time we use the Waterlow classification for the classification of malnutrition. And so good part of it is that the Waterlow classification, you take height for age and weight for height. So there we can classify this is there is an acute malnutrition or a chronic malnutrition or acute and chronic malnutrition. So it was actually introduced in 1977. So still we use it, but now because of this WHO modification, the parameters, now we use chart which is given again weight for height. That is, from that we categorize those patients between the severe acute malnutrition when the weight for height is less than 3 standard deviation, and moderate acute malnutrition when the weight for height is less than 3 standard, or between 3 SD and 2 SD. So the Waterlow classification, the weight for height, if the weight for height is more than 80% and the height for age is more than 90%, we call it normal. The percentage that you take is 80s and 90s. Again, that again have some problems, because sometimes we have taken the higher values there. So earlier I discussed the classifications which we have been using for a long time, and there are advantages and disadvantages of this classification. But recently, not recently actually, a few years back, again American Society of Internal and Parenteral Society, that they have done sort of a multidisciplinary approach to find out, to have another definition for this malnutrition. So that is called, it leads to actually a paradigm shift towards the etiology of malnutrition. There, what they have mentioned is not only the anthropometric measures, there are some other measurements also should be considered when the child is having malnutrition. So defining malnutrition with concept of chronicity etiology and pathogenesis of malnutrition and its relationship with the inflammation, that means infection or inflammation, and its impact on functional outcome. All these factors were considered to define the pediatric malnutrition. So, there, actually, in addition to the appropriate definition, the new definition of malnutrition will include relationship between what is known about causative disruption of normal nutrient pathway. That means whether there is a patient is having illnesses or not, or whether the home environmental factors have affected this patient's malnutrition. So basically, the malnutrition there is divided to illness-related malnutrition and illness not illness-related malnutrition. So that basically illness-related means the second with a disease, or in conditions a surgery or injury, or conditions non-illness related means it's secondary to the environmental factors, which include the availability of food, food security, food taboos, and all are included in this second environmental factors. So in pediatric practice, sometimes the malnutrition is due to both illness related as well as environmental causes. So this is the chart this is the diagram just to sort of categorize this new definition of malnutrition. So anthropometry will again take the parameters, weight, height, and length, the skin fold thickness, and the upper arm circumference as usual anthropometric measures that you take, and then you have the WHO references, and sometimes you can use the center of disease, the CDC parameters as well. The etiology wise or the chronicity wise, here they have categorized into non-illness related or illness related. So non-illness related is a behavioral or socio-economic or environmental factors which cause starvation. So then illness related may be acute illness as well as chronic diseases. Acute infections means the malnutrition during the period less than 3 months, where the infection, trauma, and burns again can cause poor intake, malabsorption, nutrient loss, and hypermetabolism. The chronic illness like cystic fibrosis, chronic lung disease, and all these chronic diseases also can lead to malabsorption, nutrient loss, and hypermetabolism or increased energy expenditure. There they have taken those into consideration. Then the inflammation again lead to hypermetabolism. So chronic inflammatory conditions also lead to hypermetabolism, and it can lead to altered utilization of nutrients in the body. So then this can lead to the imbalance of nutrients, either reduced intake or increased nutritional requirement. So starvation or non-illness related factors which causes the reduced intake. So illness related causes leads to increased nutrient requirement. So both in turn cause malnutrition, not only the macronutrients, the micronutrients also. So then the outcome. So it is divided on the outcome basis as well. So because of the macronutrient deficiency, which lead to loss of lean body mass and muscle weakness, and then the macronutrients as well as micronutrient deficiency can lead to development of developmental delay, intellectual disability, or the learning disability, the infections, the immune dysfunctions, and are the causes of the outcome of this malnutrition, which we discussed in different segments. So this is actually called a paradigm shift on the etiology of malnutrition. Assessment of growth in children. I think That is a very important, and everybody, I'm sure that all of you are very familiar with this growth charts from undergraduate days. So pediatricians or doctors must be well versed with this normal and abnormal growth patterns in children. And I'm not going to talk in much detail here because I want to save time to this. Uh, and I'm sure that everybody is very familiar with growth charts. Here I have shown two growth charts. On my left hand side, the child is both charts actually. In the middle is the reference. The other two growth charts which are marked where the children are growing normally. But unfortunately, not the medical people, but other paramedical people, especially in the field, sometimes still, even with a lot of sort of training and all, still uh, shout at mothers sometimes. So that's what mother comments tell us. Shout at when the child is not growing. If the child is growing in the centiles, along the centile that the child is born is enough. So therefore, we have to be very versed with these growth charts. And the growth charts are a critical part of every pediatric health maintenance. So each and every visit. So when you see a patient, even for something else, you got to look at the growth chart, and it will give a lot of information to you. And it's very important. It doesn't matter the child came with a cough or respiratory infection, but just have a glance on the growth. Then only you will catch up and you will see the children who are at high risk. Then you can intervene, you can do nutritional intervention on that point, though the child came with something else. So I'm sure that you always remember that each and every pediatric patients, though they will come with a different illnesses, you've got to go through their growth chart and see whether there is any evidence of fetal strife or whether the child is well and or they are at risk of developing severe malnutrition. So how would we assess the nutritional status of a child? So again, as you know, history plays an important role in the assessment. Here, from your student days, you know how to assess the nutritional status from the history with the detailed dietary history. Not in the dietary history, you have to ask about the common illnesses, the chronic illnesses, and the different infections and all. At the same time, not only the 24-hour dietary recall are very famous, and I'm sure that everybody is going to know how to do it. Here we mainly concentrate on the quality and quantity of food. But remember, the behavior and the feeding pattern is also as important as the quality and quantity. We only talk about in terms of energy and quality and quantity. But the quantity will definitely reduce with the problems, the behavior and feeding patterns. But still, when you are doing the nutritional rehabilitation and counseling, you got to find out what the problem, what's actually the problem is. So therefore, the detailed dietary history is very important, starting from whether it's supposed to breastfeed or whether the child was fed with any other things, or when the child was started with weaning, and whether the weaning has been given properly or not. Likewise, it's very important to have a good detailed history when you are assessing a child with malnutrition or undernutrition. The examination, again, you have to again go through all the systems to find out if there's any evidence of chronic diseases. At the same time, the, whether the child does have any edema or any dermatosis or like the features of marasmus and kwashiorkor. Then the anthropometry is an important part in the assessment of malnutrition. Here the weight is important, and we have to again base it. Ideally, we have to measure the weight 3 times and take the mean. And the height is used in a stadiometer in children above 2 years. And children less than 2 years, you have to use the infant meter. So I'm sure that we are very well familiar with how to measure the height properly and the length properly. Then the mid upper arm circumference is another parameter that we use in the nutritional assessment. Actually, it is used in the community, especially in the mass scale assessments, because it's easy to carry out, and places where you can't take the weighing scales or the stereometers. And upper arm circumference, if it is less than, it is done in the children under 5 years, and this demonstrate the way that the mid-arm circumference, mid-upper arm circumference is done is a midpoint between the shoulder and the olecranon. And the tape, which is the color tape that is demonstrated here, is used in the field clinics or in countries where there's a lot of malnutrition is present, and then the green line is normal, the red line is indicates the acute severe malnutrition. So if this mid-arm, mid-upper arm circumference is less than 110 centimeters, so that is again defined as acute severe malnutrition, and these children are at high risk of dying from illnesses because of the malnutrition. So when it is above 115, between 115 and 125, we call it, we classify it as moderate acute malnutrition. If it is more than 125, it is normal. So mid upper arm circumference is also available, especially children when the weight is when the children, if the child is having kwashiorkor, then the weight is not a good parameter to classify malnutrition, because the edema again leads to the increased weight gain. In the biochemistry, once you finish all, then you do a biochemistry and hematology assessment. In the biochemistry, you do a liver function test, liver functions as well as the total protein, the renal function, just to find out basically if the child is having any other chronic illnesses. In the hematology, it's important to find out whether the child is having anemia, and the blood picture is very important in the assessment of the nutrition status of children. Management of protein energy malnutrition is a very vast topic, and I am not going to talk in detail about all these, because again time will not permit me to talk all. But management of protein energy malnutrition, we talk in different parts. One is the management of SAM with complications, management of SAM without complications, then management of moderate acute malnutrition. So first, we'll take the management of SAM without complications. This is the guideline. I know that everybody is very familiar with this guideline. The management of severe acute malnutrition is a manual given by the Ministry of Health, and there it's give a very nice account how you should look after, how you should treat the patient with SAM, with complications and without complications. So look at these patients with SAM. What is SAM? SAM is severe acute malnutrition. So once you find the child with the weight less than weight for height is less than 3 standard deviation, then with or without pitting edema, then you categorize them whether this child is having complications or no complications. Main determinant to find out whether this patient is having
complications or not is the appetite. You check the appetite. You ask from the mother whether the child is having good appetite. If the child is having good appetite, then you consider it as a child who is having no complications with acute severe malnutrition. They are clinically well and alert. So if the child is having loss of appetite and features of infection or having fever or dehydration, hypothermia, diarrhea, so that category, of course, we categorize them as SAM with complications. Then the children with SAM with complications need inward management, and children who don't have complications, then you can manage them in the outpatient basis in the community, and again the child should be referred to a pediatrician. So in the pediatric clinic they would be look the children would be looked after by a pediatrician, the pediatric clinic, and this ready to use therapeutic formula is prescribed from there, and then the basic medical care is given in the pediatric clinic, and nutritional counseling would be done by the pediatrician, and the midwife and the community paramedical people would look after them in the community. I'm not going to talk much about the guidelines and the management of acute severe malnutrition with complications or without complications, because everybody it's available in the web, as well as it's available in the hard copies in the ward. So please go through that. It is a very comprehensive comprehensive discussion on the management. But I would like to sort of emphasize some practical points. When the child is admitted with the acute severe malnutrition to the ward, the pediatric team has to take the leadership in the management. The reason why I'm telling is, yes, now we have all these the subspecialties, right? There's a special nutrition unit. Yes, we should take their help and we should refer this child for them. But remember, the pediatric, the giving food or giving nutrition is only one part, but you have to manage the child. Therefore, the pediatric team should take the leadership in the management. And therefore, all of us know how to calculate the amount of calories and what to give, how much you should give, what is the route of how to give, and all these things should be decided or should be monitored by the pediatric team in the ward. Then once you calculate the usually for the acute severe malnutrition, the energy requirement is very high. Usually a normal child at this age, from up to the age of 5 years, the calorie requirement is roughly we considered as 100 kilocalories per kilogram body weight. Here those children, in addition to their normal maintenance, they need energy for catch up. Therefore, their energy requirement we can calculate as 200 kilocalories per kilogram body weight. But a child who is having very poor appetite, an ill child, you will not be able to achieve that energy target at once. Therefore, it's very important to start this therapeutic formula in a small amounts, a small frequent amount, and then increase up to the target level. Otherwise, you will not be able to to achieve that. Then monitor the amount that we have, or don't just try to when you are monitoring the amount given. It's very important to look at the amount the child has taken rather than the amount we have offered. That is another very sort of a problem that in our feeding charts, right? We just look at the amount that the child being given or offered, but we don't look at the amount the child has taken, because the amount we offered the child might not take. Therefore, it's very important when you are calculating and for the following day just to see whether the child has received all which we have offered or not. Then the weight chart is important, and to see the weight chart, how the usually by about 48 to by 72 hours there would be with the uh, therapeutic formula like F75 and F100, the child would start gaining weight if the child is responding. Then it's very important once you correct the acute phase and then you are taking the child through the dietary plan. It's very important to get the mother involved in the nutritional management at the ward, because she's the one who would be going home and taking the responsibility. Therefore, it's very important to get the mother's involvement in the management and do the dialogue with the health care team as well as the parents are very important in the management of acute severe malnutrition. Then the both mother and child should be rewarded in success. Right? In our setup, most of the time, the parents are, especially the mothers, most mothers are very, very upset because what they say always is doctor benna, nurse benna, midwife benna, right? So that stress will go through the baby, and then the child mother tend to force the baby for food. So therefore, it's very important to tackle them carefully. So not only the food, the child needs tender loving care during feeding. That is very important in the management of malnutrition. Right? You don't only you target your energy requirement and weight gain. You have to think about. That's why I always say the pediatric team take the leading role in the management of uh, acute severe malnutrition. Though there's a nutritional unit is available, we need their help definitely. But for overall management, a pediatric team has to take the main responsibility. Right. So actually, that's all I'm going to talk about management of acute severe malnutrition. There's a protocol, the very well defined for protocol. Everybody is sort of stick to that protocol when you get a patient with acute severe malnutrition. So then, what about the management of MAM or moderate acute malnutrition? So moderate acute malnutrition, by definition, it's the weight for height is between third and second uh, 2 SDs, and then the mid upper arm circumference between 115 to 125. Those either one of those is enough to categorize the patient or to diagnose a patient as having moderate acute malnutrition. So dietary management of moderate acute malnutrition, actually the WHO, there is no evidence or informed recommendation in the composition of supplementary food used in the management of moderate acute malnutrition. But the risk children who are at risk groups, like those children who are having food insecurity, then the WHO have just given them a blanket or target supplementary feeding. For example, in Sri Lanka, we give Triposha for those children who are having moderate acute malnutrition, but there is no set of guidelines to how much use, how to use, and how to discharge. But in areas where this food insecurity, in the WHO recommends to use this formula. Right. So now, the prevention of malnutrition or taking action to improve nutrition in the community. So, as sub-medical personnel, we have to take again the major role that we can do. So, starting from antenatal period, right? Diet and caring during pregnancy is important, because first 100 days of life includes the fetal life as well. So Proper antenatal care and care during pregnancy is important. It in turn runs to the actually the healthy teenage girls also. And then the breastfeeding is very important. Breastfeeding not only the give the nutrition but also the protect them from the infections. So those babies who are breastfed well are not at risk of developing infections, or therefore they would be healthy. Then when you starting the complementary feeding practices are very important. I think in our country this is the part we are still uh, are not up to the standard, because though I know that there are a lot of instructions are given in the book, as well as the still the extended family, and some people still you have myths on the complementary feeding. As doctors and when doctors looking after children, I think we have to give clear instructions for this complementary feeding: when to start, what to give, how much to give, and what food to take, and all should be done in very baby clinics. Then, once the child is about at the age of 1 year, then appropriate food for family diet is important. The other important factor that we have to consider is the feeding during illness. That, of course, again, we don't address much. As I told you, the vicious cycle of malnutrition starts with this illness. Illness causes malnutrition, malnutrition causes illness. So we have to break this vicious cycle. So for that, we have to make necessary action during feeding during illnesses. Especially the children with upper respiratory symptoms are the common cause for commonest infection that you come across. So upper respiratory illness leads to sore throat and blocked nose, and then the children will refuse feed often because of the sore throat, and they will not have a good smell because of the blocked nose and all. So they would refuse the food. So then we have to advise the parents to give small frequent food meals at the same time with the tender loving care, and not to force feed them at that point. Then the community growth monitoring and promotion is being done in Sri Lanka, and still I think we need to emphasize on the counseling of the food practices and all, and because still mothers are very scared to take their children for the growth. You have to remember that some children are growing in their face. They won't be catching up the weight, because 30% of children with IUGR would be remain having small stature in the rest of their life. Then the water sanitation and household food security and birth spacing are important. And then the young children, the school-based activities are important to have a proper food habits in children. So these are the basic basic steps that the community or the public health sector is doing to achieve to improve the nutrition in the community. And in my experience, that I just want to uh, emphasize, especially is the promoting of breastfeeding up to 6 months, and then you have to identify the growth faltering timely. That's why always look at the growth charts when you take the history, when you examine the baby, look at the growth charts and look at the growth trends, and act timely, and to solve the problem. Then we need to advise on proper weaning to prevent malnutrition. That is the period where children are being offered uh, 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 food which is not optimal, either diluted food is. But now, not nowadays. Now the most of the mothers know how to give food, but still, some children being fed with the diluted food. At the same time, offering food is important, because when you offer food, it will take about a week or 2 weeks for the child to accept that. That is the base, because taste. So they got used to the taste. It will take about one or about nearly 10 days to have a sort of a to get adjusted to the food. So therefore, continuation of the offering that food. Otherwise, mother would think the child refuses the food because child doesn't like. So that kind of a little information that we have to tell the mother when you are talking about weaning. So when the child starts faltering the weight at the age of 4 months, then with the working mother, so then you have to think about starting weaning food at that point. And then preparation of food is important. Again, that we have to advise the parents how to prepare food and how to improve the energy content of the food. Adding oil not only the increase the calorie value, but also it increase the palatability of the food. So adding oil is a very important thing. And then feeding of a young infant is, again, get involved the child for feeding. Don't do the, again, passive feeding. That is very important, because when you do the passive feeding or keep the child in front of the television or giving some toys or taking the child everywhere in the garden are not good. If you do so, what happens later, the child will be just a passive feeder. So he will not get involved with the feeding. And then these are the children who refuse food later, because and who keep this food for long time in the mouth, because they are not actively involved with this feeding. Feeding is a social event. So therefore, it's very important when you are feeding young infants and young children to get them involved with feeding. Then the you should avoid force feeding. As I told you, the mothers are very very keen on their children's weight. So when the weight is not good, what happens? So they will be scolded by somebody. That's what they say. I don't think that they've been scolded all the time, but that's what they think. And then what they do is the stress goes through the baby and leads to the force feeding. So then food phobia is a major problem in our setup, especially children about 11 months, children about 1 year, 1.5 years. So parents come and tell that when they see food, they start crying. So that is due to force feeding. So therefore, it's very important to avoid force feeding and get the child involved with the feeding. And the feeding or the eating is a social event. So to have a family, to get everybody in the dining table to have food since a small age will definitely would give a good outcome of feeding. So that's ends the macronutrient deficiency or protein energy to completeness of sake. I thought I would talk a little bit about micronutrient deficiency because I have only another 5 minutes. So micronutrients also as important as micronutrients in the growth, development, as well as the immunity of the children. So therefore, when you are correcting, when you are talking about undernutrition, don't forget to cover the micronutrient deficiencies as well. There are common the vitamins in Sri Lanka, the iron, zinc, folate, and vitamin A and D are the micronutrients which are deficient or which are commonly deficient in our population. Therefore, when you are treating protein energy malnutrition, you got to address to these micronutrient deficiency as well. For the micronutrients plays an important role in the growth, development, and the cognitive function performance of children. Therefore, don't forget to correct micronutrient deficiencies during the management of undernourished child. Thank you.